Next, I'll call Dr. Mahesh sir for evaluating the management of traumatic optic neuropathy.
Good morning. First, I would like to thank Dr. Piyush Kohli for having invited me here and given me the opportunity. So the topic for me is treatment of traumatic optic neuropathy. Slideshow, please. Okay. So yes, there are certain challenges in the treatment of traumatic optic neuropathy because there are no real evidence-based guidelines for the management of the same, because there are no large natural history trials or randomized control trials, because it's difficult to randomize these patients. The options suggested are surgical decompression, corticosteroids, or simply observation. So when we talk about the treatment, we talk about direct traumatic optic neuropathy as well as indirect. Direct TON is a total globe rupture, and obviously there is no treatment for this. And whenever there is an indirect traumatic optic neuropathy, we have two types: anterior as well as posterior. Anterior meaning that it could either be in the intraocular part of the optic nerve, which is the optic nerve head, or intraorbital part containing the central retinal artery, which is anterior to the entry of the central retinal artery. So in both these instances, there will be instantaneous visual loss. If it involves the intraocular optic nerve, like what we saw in Dr. Piyush Kohli's presentation, there is an instant optic nerve avulsion, and in the intraorbital part, anterior to the entry of central retinal artery, there may be a associated central retinal artery occlusion. In both these instances, the prognosis is poor. So by and large, whatever we talk is in the majority are the posterior indirect traumatic optic neuropathy, which is posterior to the entry of the central retinal artery, which occurs typically in an injury to the lateral third of the eyebrow region, here in this part in the temporal region. And whenever there is an injury which occurs here, it is transmitted directly to the optic canal, as we can see in this video. The force is transmitted to the optic canal, and the optic nerve is confined within the tight space of the intracanalicular part of the optic canal. So it leads to compartment syndrome, thereby leading to contusion. So the pathogenesis suggested are mechanical shearing, primary injury causing mechanical shearing of the optic nerve, leading to retinal ganglion cell death, and ischemia due to contusion necrosis. And what we are aiming is to prevent the secondary injury caused by vasospasm and swelling of the optic nerve within the canal. So it is this part, secondary injury, which we can prevent further damage and further vision loss. So here we can see a normal optic nerve and an edematous optic nerve. So we propose steroids, and the rationale for using steroids is it reduces the traumatic edema and limit the severity of the contusion necrosis of the optic nerve, which happens at the secondary level. And steroids may also reduce the degree of vasospasm that accompany the trauma. However, there is a word of caution here for whoever is using steroids. We have to remember the crash study, the corticosteroid randomization after significant head trauma showed that there is a higher mortality with the use of intravenous high-dose steroids. So whenever there is a severe head trauma and whenever there is a CSF rhinorrhea, we have to ask the history of all these things, CSF rhinorrhea, then we should avoid steroids because it may do more harm than good. So in summary, it was proposed that IV methylprednisolone can be given 250 mg IV every 6 hours for 24 to 48 hours if the patient presents within 8 hours of presentation. Alternately, it can be given 1 gram also IV once a day. So in summary, management: confirm the clinical diagnosis. If yes, treat vision-threatening and life-threatening injuries. Perform the CT scan of the optic canal and further treat with steroids. And if it is improved, fine, taper the oral steroids. If not, consider optic canal decompression if there is a significant optic nerve contusion within the optic canal, which may be picked up only by the MRI, and then further continue with the conservative management. And very rarely optic nerve canal decompression has to be considered. A newer novel treatment considered is an erythropoietin, intravenous erythropoietin, which was done by a Iranian group, and they have found in a pilot study and in a small study they have found that it has got a relatively equal visual prognostic outcome as IV steroids or no treatment at all. So this may be considered alternative to steroids in cases where steroids are contraindicated. So in summary, failure to treat this will result in this optic atrophy, and early intervention is essential. Thank you for your